Okay, great. For people who are just signing on now in the chat, we're sharing name, pronouns, organization, and role. And then I can do some quick introductions of the team running the webinar today. Most of you know me at this point. I'm Courtney Kenny, the Health Equity and Policy Manager at Oregon Primary Care Association. We also have Malia Tarina, who's our Tech and Slide Master. And yeah, she threw up a wave. So if you're having any tech concerns throughout the webinar, please feel free to chat her on Zoom. And then we also have Tori Baldwin. She joined us. She joined our team a few weeks ago, and she's also here today to help support the event. And I think we can go to the next slide. So as you all know, this is our third webinar for the Social Data Sharing Collaborative. The first one was a kickoff last summer. And then in October, we heard from two partners in Pennsylvania about their Z code incentive and utilization. So today we're super blessed to have two providers from Rhode Island, who I'll introduce in a few, to share how they've used Z codes at their health center. Next slide. So we're all familiar with Zoom at this point, I'm sure, but some quick reminders. You can help to avoid background noise by keeping your line muted as you're not speaking. I see everyone has done that. Please share your camera when you're speaking if you can. The chat is available for comments or questions. And it's super helpful to us if you rename yourself on Zoom, and you can do that by right-clicking your name or right-clicking your box and adding your organization, just so we can keep the attendee tracking. And then also the session is being recorded. There are a few people who can't make it today who really wanted to, so we'll be recording it so we can share it with them. Next slide. And of course, this work is only made possible through generous funding from the Cambia Health Foundation. So we're super grateful to Cambia for supporting this collaborative. Next slide. So our agenda for today, we just spent a few minutes settling in. If you're just joining us, please add your name, pronouns, and organization into the chat. I'm going to spend about 10 minutes giving a few updates for our upcoming workshop in May, and then we will all complete a survey using Microsoft Forms, a really quick one to choose breakout groups for the May workshop. And then I will hand it off without further delays to our two guest presenters, Dr. Andrew Saul and Dr. Jonathan Gates from Providence Community Health Centers in Rhode Island. And then we'll have about 25 minutes, hopefully, for some discussion. Next slide. So some norms for today. You guys have all seen different versions of this slide throughout the collaborative, but we would love it if you could be as present as possible, focused and not multitasking. I put away all other things, and I really hope that you will too. We love seeing your faces. So I know we're all webinared and computered out and working in the matrix, but it's really awesome to be able to see your faces. So turn your cameras on if you're comfortable. The discussion time will be really fun if everyone participates. So I really hope that you'll join us in that 25 minutes and bring your questions. And then also, I acknowledge that for a lot of people, this is lunchtime. So please feel free to eat. We don't want to steal your lunch from you. Next slide. So here's a really kind of reduced version of the May workshop series agenda. I sent out the more detailed version of this one, and then also the detailed daily agendas on April 5th in a packet of materials. And then the other materials to be aware of are all of your team PowerPoint templates are in the Google Drive homework folder. They're also linked throughout that packet. If you don't want to go searching for them for those days, you can link right into your PowerPoint. So what you're looking at here, the kind of light gray, greenish color is work that you're doing on your own over those 3 weeks. And then the bright orange color is our workshop days where we're all on together. The biggest thing I want you to take away from this is that team presentations are going to happen on the first day. So before May 5th, make sure that your team PowerPoint is completed. We're asking for a little bit of data in this one. So please make sure that you've looked at that and that you feel prepared to do that before May 5th. On the second day, we'll have some discussion groups, some pretty long ones for about an hour. And I'll go into that in more detail in a moment. And then on the third day, we'll have really brief team presentations, really exploring if you think that your organization will continue using Z codes and how after this collaborative. And then we'll repeat our baseline survey from last summer as well. Next slide. So with team presentations due on the first day, we wanted to make sure that we were offering opportunities for support if you all need it. So in that email, I sent out a list of potential office hour times. If you would like to join office hours or you need some extra support, just let me know and I will create a Teams invite for us to meet. If these dates and times don't work for you, I can be flexible. The most important thing is that you feel like if there are issues with the homework or with the event that we're there to support you through them or make changes as needed. Next slide. So our breakout activity on the second day, we'll be breaking into groups to discuss Oregon's readiness for social data sharing, as well as some other system level considerations. And we'll be having you choose a group of the perspective that you find the most interesting or that you're the most passionate about, and really sticking to answering that series of questions from one of these perspectives. So group A is really CCO and or payment concerns. Group B will be quality improvement and data standardization at the system level. And then group C will be clinic implementation and patient-centered care concerns. So the next slide is us filling out that form where you're choosing your breakout group. If you need a sample question, I would think of that second one at the bottom of the slide. What infrastructure and investments are needed in Oregon in order to support social data sharing? So we'll go to the next slide and I will link the form in the chat. Mouse would work. And I don't know if we'll need the whole 5 minutes, but I'll wait till I get a good amount of responses come through. And if you have any questions about the breakout groups or how to choose a group, please feel free to unmute and let us know. You guys are really fast. I'll probably give it like another 90 seconds. Thank you. Okay, I think that's just about everyone. If you're still working on it, that's okay. And we'll also send out the link by email for anyone who didn't make it today. So next slide. So that's all I have for opening remarks. Without any further delays, I'm going to hand it over to our two presenters from Rhode Island. We have Dr. Andrew Saul. He's the Chief Medical Officer at Providence Community Health Centers, and Dr. Jonathan Gates, Chief Medical Officer for Accountable Care at Providence. So I think, yeah, so Dr. Saul, we're ready for you to share your screen. Looks like you're doing that.
Try and make this work. How's my voice? Is this loud enough?
Perfect.
Can you hear me? Okay. Hold on 1 second. I'm rebalancing my audio. Okay. Can you still hear me?
Yes, and we have the presenter view on your screen.
Beautiful. That's not what we want though, is it? Anybody have a way to toggle this over?
So let's see.
It usually opens two
I know.
windows
This is
there.
the joy of the sound check.
Maybe end it and try it again.
Yeah, usually if you do end screen share and then go to the other one, it'll
Got it.
switch over.
Or if you share
How's
the
that?
PowerPoint application and set up your
Mhm.
whole screen, maybe that will work.
What's projecting now?
There we go.
Got it.
Oh, good. Awesome. Great. Hi, I'm Andrew Saul. I'm a family physician. I am in Providence, Rhode Island with my colleague, Jay Gates. We'll introduce him momentarily. Today, we're going to be discussing Z codes. And about a month ago, Courtney called us and said, can you help? And we heard that you guys were on this journey. And both Jay Gates and I said, wow, that sounds familiar because we were in your shoes just a few years ago. So we're kind of talking to you from the other side of chaos here with a little bit of hope. So I will try and make my screens advance now. And of course it froze. So now I'm going to stop sharing one more time and relaunch it again. Hold on. This is always fun, you know? Let me try and project this one. It says it's a PowerPoint slideshow, sure. Okay, what's projecting now?
Your desktop.
Good, I got the right version running. So hi, I'm Andrew Saul. I'm a family physician, also a clinical informaticist, and I've got a health degree in policy. And when you put that rare combination together, insurance company people really hate it when I come to meetings because I love to talk data and beat them over the head with social justice and community health center stuff. Dr. Gates, do you want to introduce yourself?
Sure. I came to Providence Community Health Center because Dr. Saul was really nice to me in my interview. I came from a decent sized health system in Rhode Island, Care New England, where I worked my way through Director of Patient Safety and played with the Cerner Millennium EMR and then helped put together their Epic ambulatory EMR and learned about Medicare and Medicaid ACOs and how to run them. And now we're doing this mostly for Medicaid, but we also have a Medicare ACO at Providence Community Health Centers.
And of course, first things first, we have nothing to disclose. We're poor, we work for a community health center, and most importantly, we're not here to sell you anything. So sit back, relax, eat your lunch, and let's talk turkey about how to get Z codes and other data from your office to who needs it, whether it's a CCO or your state Medicaid office. And in case you didn't catch the gist earlier, we are from the original Providence, Rhode Island. We've been weird since 1636. And why are we weird? Well, because we were all kicked out of Plymouth Bay Colony for having the audacity to suggest that women and Native Americans should have a say in things. So we are not Providence from Portland. We are Providence in beautiful downtown Rhode Island. So a little bit about our health center. We have 60,000 patients, a big chunk of kids, about 70% Medicaid, 10% uninsured, and a whole lot of Medicare. We're running 8 multi-specialty clinics across the life spectrum, and we do have a bunch of specialties in-house, including derm, optometry, podiatry, and a very large urgent care. We've been a Medicare ACO since 2014, and that was a disseminated federated model with some other community health centers around the country. And we've been doing the Medicaid ACO, alternative payment methodology, APCM, whatever you want to call it, since about 2017. This is now project year 4. It's still evolving. And you'll see that some of the stuff you're doing now with Z codes will pay off in the future. So hang in there. And also when we do commercial contracts, we also do capitation now. So we learned how to ride the bike and we're not too afraid. So I always like to start a lecture I give with the big caveat and warning that I have a lot of opinions. Forgive me in advance. But one of my favorite things of all is to remember we, the community health centers, we've been doing this for 50 years. We're talking homelessness, Z codes, social determinants, and now 30 million Americans get their care from community health centers, and we know social determinants. And by we, I mean you and we, all of us. And it goes right back to Hatch and Geiger there at the start. If you want to improve health, you need to break the cycle of poverty. Housing's key, nutrition's key, and the community has to be able to take care of itself. Why does this opinion matter? Because my health policy thing is, how did health centers get into this whole prospective payment reimbursement methodology? PPS is what it's called. It may have worked well in the initial decades, but it's got some problems with sustainability. In fact, a lot of the states are now pushing for these alternative payment methodologies, and they want to shift some risk to community health centers. And that can be scary for a lot of people. Right now, these APCMs or APMs, there's a lot of different acronyms. Of course, you've got the PPS safety net to keep things together. And like I said before, these statements do not represent the opinions of my boss, my health center, my state, or pretty much anyone else in charge. But someone has to say it aloud. States recognize that PPS is not sustainable if you're going to be doing population health. And so we need to figure out how to get to that next generation. Some of the other opinions, hey, states can be very innovative. These state Medicaid offices can be good or evil, depending. But also remember that community health centers are very, very good at population health. We've been doing it for a very, very long time. And so as you go on this journey in Oregon, remember that health reform is indeed a journey, and it's not a zero-sum game. So as you get into these discussions with Oregon Health Authority or your CCOs or anyone else, remember it's not zero-sum, that a lot of the efforts you already do can be additive, and it can really break this cycle. Also, learn how other parties define success and see the world through their eyes. I had to learn to speak HEDIS to talk to insurance companies, but now that I understand how their game works, I'm able to find that win-win solution to really make things better. And above all, know that you're not alone. Lots of other community health centers around the country are on this journey, and there's a lot of good resources here, and we are glad to share with you so that you don't have the nightmares that we did about 5 years ago. So, thinking about the road ahead, is your health center really ready for risk-based contracting? Boy, I hate that fiscal term. Let me phrase it differently. Is your health center ready for social determinants of health and whole population care? And everyone goes, well, yeah, we know social determinants. We've been doing this all along. And what these risk-based contracts can be, if you help guide them to creation, you can actually get population health viewed through the lens of social determinant. In other words, that's the mission of the health center. And the thing, though, to remember is that the all-inclusive PPS rate that's gotten health centers where they are for the last 30 years was really designed for people who show up. That patient who comes to seek care, who's got every imaginable social barrier to care, that's great. That's why we have that enhanced rate. The problem is that was never meant to cover the people who are attributed. Let me say that another way. In fee-for-service, we take care of people who show up. When you start talking alternative payment methodologies, they're talking about those who show up and those who don't, the attributed lives. And so, of course, that's the paradox. What do you mean there's more to a population than just caring for those who show up for their visits? So I want you to think big here. PPS was intended to take care of those who show up. But if you really want to do this, you're going to need infrastructure that supports things that PPS could never do, things that you always knew you wanted. Some of you may already have nurse care managers, integrated behavioral health, community health workers, all those things that you were doing already. And it's not just strategies for those who show up, it's for those who are missing in action. So as you look around the bend from Z codes and all this, you have to look at those PMPMs that you were talking about. So in Oregon now, you're a couple years into this, and I know some of you are getting those advanced per member per month, PMPM. Some of you are getting incentivized to submit Z codes. Hooray, that's a start. But here is kind of the great big picture. So you're kind of in the purple box at the moment. If you get that infrastructure, hopefully you can develop these enhanced care teams, reduce provider burnout, get all those innovative things you always wanted, little care coordination, and begin to transfer data. And hopefully those look familiar, because this is some of the data you guys are transferring right now to your CCOs. And if this goes well, while you get that PMPM, you still have the safety net of PPS. But remember that right there in the model, this is a stage. This is an evolutionary stage to get everyone to bridge towards value-based care. Now, if you want to see something breathtaking, we're kind of stuck over here in that foot in two canoes stage, which is really intriguing. We're not where we need to be yet for value-based care. But that foot in two canoe stages is actually about 10 steps. It still fits in one arrow. And if you guys haven't met Art Jones yet, you really should. He's with a large community health center in Chicago called the Medical Home Network. They are a very successful inner city, urban, FQHC-based ACO, Accountable Care Organization. And a lot of the stuff you hear me spouting, I learned from Art Jones. In fact, he's coming to talk at our state meeting this Friday. So I'll just say it again, Art Jones, if you want to see where I'm getting my crazy ideas from, he is the Yoda of this whole process. And since he works in a community health center, he's very, very good at guiding state Medicaid offices through this process as well. So here's what life looks like on the other side of Z codes. In an ACO, an accountable care, APM, whatever you want to call it. Here's the formula. Predicted total cost for 10,000 or 20,000 people minus actual cost equals savings. If you succeed, you share the reward. If you fail, you bear the risk. Holy cow. And of course, when we say potential savings, just a few strings attached. Actual mileage may vary. Please see your dealer for details. But that formula, predicted minus actual equals savings, will come to haunt you. So the idea, of course, is how do you predict total cost of care? How do you predict who's going to get in trouble and spend more money and need more resources? And if you could intervene, maybe you could keep them from getting sick in the first place. So I understand that next month you've got somebody really cool coming, but here's kind of the groundwork of how it all ties together. When it comes to predicting who's going to get in trouble and cost money and need resources, there's two phases. One is to recognize who might get in trouble, and the other one is to intervene. And the recognition part is done through risk-based risk adjustment. And this is what next month's person is going to be talking about here. I'll leave that to them. The devil is in the details, but suffice to say you can cram more high-powered ICD-10 codes through the system to say, yes, my patient is high risk. But the part you already know, the part you've been doing, you just didn't know you were doing it, was this. And it's risk stratification. In the population of the people you serve, you've been trying to figure out where to target your limited resources. And let me tell you, if you can identify homelessness or housing insecurity, that is pretty much a great way to begin to learn to play the game. So risk stratification is the strategy. You know that. Risk adjustment is an evil, horrible game that you need to learn to play. More details coming next month. So of course, we go back full circle. How do you know who's going to be the highest cost, highest utilizing? And I'll put a plug in. Yes, one more time. Somebody said prepare at one of your state meetings. I'm sorry. Congratulations. You guys helped develop a really cool tool. And the rest of the country is using this tool. We twisted it around a little bit. You would recognize the framework, but we added in stuff from NCQA for patient-centered medical home. And then we modified the questions using Health Leads. I'll say it again, Health Leads out of Boston is a consulting group, and they help you develop low literacy questions. And it really does matter how you ask the question. So we basically polish the questions a little bit further to work with a low literacy, highly ethnically diverse population. And hooray, we now screen for homelessness. Actually, we are screening for the entire bevy of the social determinants of health: food, housing, legal, and also domestic violence. But wait, there's more. If you want to really really survive and thrive, bearing risk, taking care of a population. We're also screening for depression, the great multiplier. When you've got depression interfering with heart disease, it just doubles the cost. People who are depressed just don't get better. You have to address depression and anxiety and substance abuse. And now this sounds logistics because I can hear your head spinning. Wait, we're having trouble screening for Z codes and moving that data right now. What do you mean you're doing all this other screening? Well, let me tie it back to the mission first, okay? This isn't just about total cost of care and saving money in somebody's alternative payment methodology. This really does align with your community health center's mission. And when we started doing this, of course, we need to react and respond. This is actually good for the soul. And since we started doing this and we can now respond in real time, morale's a lot better because finally we recognize that you can't treat diabetes if they can't get access to fresh produce. Okay, what are we going to do about this? Let me call the food bank. So here is what our tool looks like embedded in an EHR that you've never heard of. It's available in several languages on the front end. We can do it on clipboard. We can do it on a kiosk. And we did modify it for low literacy in a multi-ethnic population. We built it deliberately to be structured data, and structured data means, ooh, I can run a report. You're right, and not only can you run a report, you can also crosswalk it to that ICD-10 Z code for homelessness on the back end. So I didn't want the docs and the NPs and people on the front end trying to look up the Z code. Basically, if it shows up here in the screen as housing insecurity, someone can bring it into a Z code if needed later. So of course, our strategies, not surprisingly, synchronous during the visit. We might do it on a clipboard in the waiting room, might do it on an iPad in a kiosk while they're waiting or in the room. Of course, the key thing many of you know is if you try and do a 5-minute screen every time you put a patient in a room, you're going to crash your system. So always be aware that the more you screen, the more harm you can do to derailing the docs and the nurses and throwing them out the window. Don't do that. So we're beginning to look at this asynchronous model, which means, ooh, can I mail it? Can I do it over the phone? Some of our community health workers call and do these over the phone, particularly our Medicare patients. Can I use the patient portal? What's a patient portal? No one has a PC. Move on. Do it. Can I get it on a cell phone API? Yes, you can. Talk to your favorite vendor. And of course, the strategy of the screening plays a bigger role. And like I said, if you've not seen how the ACOs around the country, community health center ACOs are doing this, it always comes down to doing what we do best. And it's this screening for food, housing, legal issues, and interpersonal violence. And it's so fundamental, it's actually a best practice. So what you're doing now for Z codes, be ready to amplify it and build on that foundation, I think is what I'm trying to say. We do measure how well we screen. We're not quantifying exactly how well you screen, but at this moment, we just want to know how well your care team does screen. And then we respond to the data. We care so much about screening, we actually tied it to the care team's incentive plan. And right now we're gunning at the state level for 50% of people should be screened once a year. In-house, we have teams doing 80 and 90% screening rates. So we want to celebrate that when it's done, so long as it doesn't crash your system. And behind that, of course, hey, we have a school of public health, so do you. People come and they do wonderful, glorious papers here. So the top white line where it says pre-COVID, hey, there's 20,000 people and you can see the baseline rate for housing insecurity. Below that in the red box is what happened through the pandemic. No surprises. You see food insecurity go through the roof, housing insecurity went up 400%, and interpersonal violence doubled. So if you're gonna build a system and do this, make certain that it ties back to your whole community health process because you can really do a lot of good with this. But of course, screening isn't really why we're doing it. We don't screen to screen. We screen to intervene, and you've got to have a plan for what you find. And of course, if you're a community health center like us, you work with partners, lots of partners. And we have spent a long time rebuilding these bridges to other agencies. So as we find somebody in need, we are connecting them and linking them to community resources. So it's really, really nice to be able to do something when you do find it. Personal plug here, community health workers, in the 5,000 years of recorded human history, this is the public health strategy that works. If you give me an army of grandmas and aunties we will change the base of healthcare. So give me those community people who speak the language, who know everybody and can go door to door. You too can really change the setting where you live. Now, of course, at this point, you should be asking, you're preaching to the choir, dude. I know, I couldn't resist the segue. I did get PTSD when Courtney told me where you guys were in this, and it took me back a few years. I'm going, okay, hang in there. I'm here to give you hope. You should be asking yourself, we're a room full of community health centers. We do this. I know that. We know why we should screen. Yeah, I bet you do. And you know how you should screen. And you're already talking about best practices of how to get that screening done. And of course, Courtney said, could you come show us how to move the data from point A to point B and J? And I said, okay, cool. And in case you didn't figure this out already, I challenge you to look beyond the Z code, because it's not just a Z code. It's not just one ICD-10 thing. We're talking about all the data you're measuring for the CCO, diabetes, blood pressure values, all this other stuff. You need to figure out how to move the data from point A to point B. And Z codes are just the tip of the iceberg to help you describe relative risk. And so, Jay, this is the new slide I warned you about. This is your 30-second notice here. Sharing flat files can only get you so far, because as you scale something up, the complexity goes up exponentially. So here in Rhode Island, you can see those ACOs, that's basically the community health centers on the left. The payers, the CCOs, are those purple boxes. It's a very interesting relationship here, but we have a data warehouse where we push all these different types of data at high volume into this. And then the state Medicaid office can get what it wants, and the CCOs can get what they need out of it. But a bunch of us looked at this and said, why are we adding more complexity to something that we already have in place? And it turns out Oregon has this in place also. So I want to give a shout out to your Health Information Exchange. If you are an FQHC and you have not been at the table with this process, you've really got to get on board. This can really change the way things work at a community level. So the root cause, of course, is EHRs don't talk to each other. And that lack of communication between hospital to clinic and specialist back to clinic, this harms patients and increase costs. You can insert your own horror story here. So around the country, we're doing these HIEs, Health Information Exchanges. They're a start. What Oregon's doing is regional right now. Rhode Island, hey, we're small, but we built a statewide HIE. Ours is about 10, 15 years old. It's one of the oldest in the country. But as you approach yours, I challenge you to think statewide instead of regional. And here's why. Because that HIE can move all of this data that you're looking at, including the quality data. So this system is already right there. It just needs to be repurposed and tweaked a little bit. And it may save you years of headache as you look at this process of moving data. Who runs your HIE? I believe the Oregon Health Authority runs your stuff. But in case you didn't know, the absolute mecca for clinical informatics in America, my humble opinion, is Oregon Health Sciences. These are the data geeks who know this. They call it DMICE, D-M-I-C-E, Department of Medical Information. There's the link. Pick up the phone and somebody make inroads down there and say, hey, we have a very interesting problem. I've got a handful of CCOs, and I've got 50 different FQHCs. We've got unstructured and structured data, and we need to move it from point A to point B. So with that little hint that there are ways to move data differently, I'm going to turn it over to Dr. Jay Gates.
Thank you very much. I will attempt to share my screen. One moment. How does that look? Looks good. All right. So as Dr. Saul pointed out, there are a couple of different languages involved. I think you are all very confident speaking UDS in terms of your quality measures. And then this is how we use our internal data, how we justify some of our existence for funding. And they are pretty similar to some other things that are used in EMRs for tracking quality. We don't, however, see a lot of the information that's out there in the cloud, in the world, if you will, the things that follow our patients around. And that would be things like the mammogram claim if the fax didn't come through to us or it got gummed up in the machine, or if perhaps that was done by the obstetrician that's not part of your group, went back to them and not to you. On the other hand, our insurance friends do see that. And so they come to our door and say, hey, just so you know, you met this quality measure, which of course was not really what we wanted to know. We wanted the report as clinicians. But there is value to knowing what things have been closed and what haven't. At least we know who we have to call in order to figure out what happened. But they usually look at things like CPT codes. Sometimes they'll get an ICD-10 code to justify medical necessity. That's what that's all about. But they can't see all of the things that you've collected, like blood pressure and A1C. They've invented some ways of doing that called F codes, and usually it's pretty painful to submit them unless you have very specialized EMR pathways. And to figure out any kind of hybrid measure, anything that has to be extracted from the EMR, a lot of times at the end of the year, it comes down to them auditing by hand, getting a nurse to look at your electronic medical record, which is both expensive and potentially fraught with the usual human error. So neither of us have all of the information. We do need each other actually to succeed in this until at least we have those HIEs fully up and running. And I think we have to figure out how we can leverage our expertise in this setting in order to avoid this wonderful train wreck on the bottom right. This is a diagram I'm not going to go over in detail. I urge you to look at it when you need to go to sleep this evening. But what it does say is that a CCDA, which is a technical term, which you can also look up tonight, contains a lot of information, and it's part of meaningful use. So your electronic medical record, assuming you must have one by now, puts a lot of this in there, and it's also structured information for the most part. So things like those labs that the insurance company doesn't have, the vital signs that they don't have, all of the diagnoses on a visit, not just the ones that have been associated with a charge, for example, can go in through this. They can find their way through your HIE, which the state may want to use for things like syndromic surveillance or a vaccine registry, because those can go into your CCD as well. They may want to get the quality out of it. That can be normalized by the state in terms of keeping a master patient index, and then you're trading information on the same person for identity management. And then one path of information goes to any number of insurers. So you don't have to maintain, build, and functionally pull your hair out over multiple different flat files because Blue Cross wanted it one way and another insurer wanted it another way. So advantages of an HIE and CCDAs, you get a whole picture of the patient's risk because there's also the problem list there. Remember, when you submit an encounter for the charge, you're only getting the encounter diagnoses, those things that you addressed during the visit. But the problem list has all of those chronic conditions that you're tracking that you may not have addressed on that. So there's a bigger picture of that patient's risk enabled through the CCDA. It's existing technology that's fairly standardized, not 100%, but fairly, no bottlenecks. You don't have a limit for your claims engine of 8 or 12 or even 25 ICD-10 codes. There are some issues. Not all EMRs stuck to the standards. Identity management is no worse than it could be. And your CCO might actually have to give you more analytics. I don't know if they want to do that or not. This has been our experience with that. We found that our EMR was not importing some of our screening codes. I'm not going to go into that except to say it was frustrating. Our state HIE did develop a mapping of some of those custom codes inside our EMR to the Z codes so the insurers could interpret those. That was nice of them to do. And then what was good about it, though, is that all of our ICD-10s, even the unaddressed ones that you find in the problem list, are going to the HIE, so the state can get a great picture of the complexity of your actual patient panel, whether or not you submitted them. labs that the provider cites into their encounter are also going over there. I mentioned cites in because not all EMRs will put in all labs. It's only the ones that the doctor sort of recognizes they looked at that tend to go in there. So a little imperfection there perhaps, and a good argument for your state having lab feeds as well, as many of us found out during COVID. So coming back around full circle, I'm going to do the adult learning pattern here where we looked at this one more time. Dr. Saul introduced how accountable care works in general. I'm just going to show you how it plays out for us. So for us, our incentives are that shared savings, and that is our predicted cost, which the state figures out now for us, and our actual cost, which our insurance companies figure out for us. And then they multiply it or divide it, as I'll show you momentarily, by our quality score. Now this turns out to be about 3% of our budget. So we have one giant canoe on one side and one itsy bitsy canoe on the other side, but 3% is 3%. And as you all know in healthcare, that can be the difference between being in the black and being in the red. So we do pay attention to this. And as we mentioned earlier, this aligns so well with our mission. It's lovely. So the population risk score, those ICD-10s that you're passing through your claims engine and so forth, are driving the predicted total cost of care. Unfortunately, to my knowledge, there's no weight associated with Z codes at the present time. I'll say that one more time. Unfortunately, for reasons that are totally beyond me, there's no weight associated with Z codes at this time. I'm going to show you the weight. It's there. It should be. Shared savings can be reduced if you don't have good quality. So they wanted to make sure that we weren't just saving money like the HMOs might have done in the early 90s, hint, hint. And we get a quality gate in your terms, and we call it a quality multiplier here because they wanted to make sure that we were getting more money, not less. That's not the way it works. Social determinants of health is one of our target quality measures. Depression screening and follow-up being documented is one of our hybrid measures. Doesn't necessarily come out in the claims feed. And so we do trade flat files in addition to that CCD exchange I mentioned. Now, we also have these things called performance measures. And what you can do is substitute these in your head for risk that drives cost at the population level. And if you think about it, I like to call them alternative quality measures. Because let's face it, if your patient gets readmitted to the hospital in 30 days, by the way, I used to be a hospitalist, I might be someday again. If they get readmitted in 30 days to the hospital, then the warranty did not work, right? We didn't fix the problem, or we didn't catch the patient well enough. We didn't bring them back into primary care. Somehow that they fell through the cracks. That's a quality failure in my book. ER use in patients with mental illness. We actually use your own definition. We use Oregon's definition for behavioral health ER use. I rather like it. What we find in this group is that because of the mental illness, by the way, there's a whole constellation of different levels of severity and different types of mental illness there, if you haven't looked at it. They end up in the ER, not always, often not because they should be in the ER, but because there's no one else to help them. I'm sure that's not an unfamiliar issue for your clinicians. And then avoidable ER use in our whole population. Avoidable ER use being usually defined as something that the primary care doctor could have taken care of in the office if there'd been an appointment available in the next 12 to 18 hours. And what I usually do is say that third one is how much same-day access did you have? And how good was your nurse at answering the phone, or how hard was it to get through to your nurse? Take home from this, we have to accurately submit our ICD-10s, and we have to be accurate about which ICD-10s we pick to make sure our risk scores drive our predicted risk high. We have to keep our patients out of the emergency department by making sure they can see us easily. And we have to avoid readmissions, because the readmissions have a mortality associated with them. They're not good for anyone. They're usually much more costly than the original. And we all still have to do all of this while balancing good preventative quality, much like you're used to doing today. Homelessness. All right, how many people think they know what homelessness is defined as? I'm not going to wait for you to answer. It's okay. Here we go. I have living in a place not meant for human habitation. I have losing my primary nighttime residence, living on a couch or doubling up with somebody who didn't necessarily plan on me living there. I have families with children who are, or unaccompanied youth who had 2 or more moves in the last 60 days and who are likely to continue being unstably housed because of disability, multiple areas of employment. I have fleeing or attempting to flee domestic violence, have no other residence, and lack the resources or networks, social networks to obtain permanent housing. So there are at least 4 distinct populations here, probably 5, 6, or 8. There are only 2 Z codes so far to really define homelessness. And there are thousands of potential solutions to each of to this bevy of different populations. So although I'm going to show you how these Z codes convey risk and they convey cost that underlies that risk, the Z codes in and of themselves are not going to tell your insurance companies, they're not necessarily going to tell the state what to do about it. The only person that's going to really know that is probably your providers and the degree of detail that's in your prepare form or your documentation in the EMR. So I would think about the granularity that you can afford to collect in a 15-minute interview and how you go about managing that stuff. This is a lovely graphic, which I put in here to point out that primary care, as you can see the sliver over here on the right, is only what, 10% of the spend in the population for Medicaid. Pharmacy, a big chunk, working my way from right to left. Hospitals and specialty, big chunk. Long-term care facilities. So there's no doubt that as you move from value-based care away from volume and fee-for-service, PPS, what we've been talking about, to value-based care, the good news, I think, is that primary care, this percentage for primary care is going to increase. You're going to pull your patients back away from the emergency department. You're going to pull them back away from getting readmitted to the hospital, and you're going to keep them at home seeing you healthier. That's the whole point. Transfer the money that's getting spent ineffectively here and spend it effectively here through whatever means you think are best for your population, through your community-based organizations, through food prescriptions, whatever that might turn out to be. So let's take a look at this. Utilization, right? Utilization is a nice complex word, which means how often did I fail to keep my patient out of the ER or the hospital? What I have here are 3 different populations. The first one is all of our patients that are in our analytics database. That's the whole population column. The second one is a combination of 3 different scenarios in social determinants. In there, I have housing insufficiency, I have employment insufficiency, and I have food insufficiency. So that's a mix of all 3. And on the far right, I have only the housing insecurity Z codes. So let's take a look at what happens when one of these are present, one or more, I should say, in the middle column, versus just housing is present. If I look at my ER visits per 1,000 patients, average patient, right? 38 visits per 1,000 patients, whole population. If I put in housing insecurity, that goes up to 204 visits per 1,000. If I use any of the social determinants, probably more than one in many cases here, it goes even higher, almost 300. There are very few risk factors out there in HCC land or CDPSRX, however you want to find the code for it, that drive this level of increased risk, cost, and utilization. That's the Z code's power for you right there. As I look at my acute inpatient admissions, it starts off at 9 per 1,000. So 1,000 patients over the course of a year, 9 admissions. It's almost 10 times higher when we throw in one plus social determinants of those, just that, there's the 3 subset there. As I look at my readmissions per 1,000, it starts off at 1, because most people are healthy in Medicaid. If they go to the hospital, they don't get readmitted because it was something, pneumonia. It's cured, 31.22. Very, very high. Big differences. So Z codes for homelessness predict at least a 4-fold increase in, and I put in parentheses, misutilization of the ER and inpatient admissions. It's a little unfair of me to say misutilization because you know what? Most people who work with the homeless would tell you it was totally appropriate for them to go because they didn't have anywhere else to go. We haven't built that place for them to go yet. And if you need a warm place to stay at night, and that's the one that's paid for right now, that's where you should go. So let's take a look at 2019 versus 2020. And these Christmas graphs, as they've been dubbed, with wonderful red and green. I didn't get a chance to pick those colors. That's how our analytics platform came. The height of the column here are the cost of the facility. And a facility means that it is, generally speaking, a hospital or something a hospital owns. And the reason I call out facility fees is that at a hospital, they usually get a bump in their facility fees to help them defray the cost of keeping on, neurosurgeons 24/7, making sure the ER is open 24/7. So when you go to a hospital, you are paying a premium for the convenience of them being there 24/7 and having specialists on call and so on and so forth. That's okay. We need hospitals, and don't get me wrong. 2019, our average per patient per month, so the amount we would spend per patient per month on a patient who has a Z code, Z59.0, was running around $437 per month. As we looked at what happened over the year of COVID, we saw that that average doubled. So as our community saw the stress and the deterioration of the social network, can I stay on your couch tonight? Oh, no, you probably have COVID. We saw, as these turn red, by the way, the color is the cost here, and the facility fees are in the height. They started winding up in facilities, higher cost from a facility standpoint, and that was driven, their per member per month cost was driven by that facility fee. So if we don't provide in an accountable care organization, in a value-based care, if you don't provide a place for people to receive housing, whatever they might need, they're going to seek it in the safety net, as we like to call it, the safety net of the ER in the hospital, and it's going to cost you a minimum of twice as much. We can't afford that. You can't afford it, and this is why value-based care is getting moved forward. Let's look at their inpatient admits per 1,000. So an inpatient admits per 1,000 is the height of the column here. And as the pandemic came across here, I mentioned social stress. I mentioned that ability to depend on what social network you had when you're homeless. It was made worse. You don't have the ability to call up somebody if you have a phone. That also interfered, though, with PCP access, primary care access, because a lot of us had to close down some or all of our in-person visits and go with telephonic or, in some cases, video. Don't get me started on who has internet access for video, right? So in 2019, we had maybe a peak of, say, 50 inpatient admits per 1,000 in the homeless population. As we get into 2020, we're seeing a peak of double that once again. So inpatient admissions, and by the way, these are not short stays. These are solid 3+ day admissions, really started to peak. Again, per member per month cost started to increase. I can't tell you exactly what happened here, whether this was COVID related or not, but they were suffering. And if you don't look for it, you won't see it. By the way, access in this setting is not routine follow-ups, visits, and annuals. Access is, I feel sick today, I need to see you now. That's not easy for a primary care practice to provide. Our model happens to use open access. Right now, we're running around 35%. In the past, we've been as high as 65%. It's a good thing to think about. So remember that behavioral health cohort with the Oregon definition. What I did was I took all of the ICD-10s that go into the definition of that measure and made a cohort of our patients who have had that one or more of those ICD-10s billed for them in the past 5 years. So that's how I sucked them into this cohort. And I said, let's look at what happened to them in 2019 versus 2020. So a wide range of different kinds of behavioral health diagnoses, anything from anxiety disorder through severe persistent schizophrenia. And once again, I'm starting off around 400 here. There was some increase over the wintertime in 2019, but they're definitely they're running much higher over the summer during COVID. Again, you're seeing that impact in your community of a drop in the ability to cope, and they wind up going. In this case, the color is ER visits per 1,000. So there's normally a bit of a peak in the summer in ER visits in this population, but you saw it persist and the cost got much higher. One last thing. As you go into value-based care, and you think about capitation means you get your money no matter how many people you see, right? You don't actually get to work less hard. Oh, if it were only that easy. What happens is you wind up having to figure out how to work just about as hard, but see the right people at the right time. And that's how you manage risk. And I put this up here. This is a graph that shows the relationship between our no-show rate and those patients' PHQ-9 score. Now, when I first put this up here, I didn't believe it. I had to check the data a few times, because those of you who have done statistics or population health will know that an R-squared value of 0.48 is unusual, okay? That is a very strong correlation. It's also not surprising that if somebody's having depressive symptoms, they may not show up to their doctor's appointment. Now, in the past, in a pure fee-for-service world, we've all heard stories of the offices that will say, you no-showed to the last 3 appointments. I wonder how we're going to manage that. In a value-based care organization, not only are you going to say, come in and see me today, you're going to make sure that you call and say, can I get you a ride? Come in. Because that's what this person needs. They have some depressive symptoms. They're not able to manage for whatever reason. Maybe they have social determinants that they're dealing with. Maybe they have complicated family stress. That's why they're not showing. It's not because they weren't prioritizing their healthcare in some personal way. So make sure you think about no-shows as a sign, a call for help. That's the point of this graph. You have some take-home messages?
Yeah. So I'll take this one. You want to hit advance, Jay?
I will.
So as we wrap this up here, remember that if we can survive alternative payments, so can you. Oregon led the way for decades in doing a lot of the social justice work and prepare. We are building on your work. So don't be afraid to go forward, but you do need to have a seat at the table. So no one is better at recognizing and responding to the social determinants than a community health center. When you look at all the different things that drive total cost and risk, oh my God, housing. Yes, that's a great one to get your feet wet on. Go for it. But remember, it's more than that. It's food insecurity, domestic violence, and everything else we were talking about. Basically, it's another day at the community health center. That's what drives total cost. And we are quite literally at a generational crossroads. For the first time ever, your fiscally conservative CFO will want all those bells and whistles that don't generate revenue. They will want that to work. because the community health workers, the outreach workers, they can help reduce the total cost. So be early, be active, get those CFO people on board with you. You too can take advantage of this generational opportunity to really transform healthcare. For the first time, we got mission, we got money lined up. Let's make a difference with the world. Jay? Oh, there it is, the CFO slide.
Sorry, I missed that one. So do know that SDOH can partially be represented in Z codes, and so can the risk that it conveys. You can predict cost and utilization, and you know that you have to go after these folks. They need your help. That's clear. Think bigger than just screening for homelessness. Obviously, SDOH as a panel, we saw that in multiple domains that they predict utilization. And as I said, utilization is a fancy term for a failure of our system. It's an alternative quality measure is really what it is. The social determinants are usually additive. So if you've got more than one, it causes an even more difficult time for patients. Conditions like depression, they're pervasive, they undermine care plans, and they multiply total cost. And time and again, you can create any cohort you want. If you add in a depression diagnosis to that cohort, you will see the same kinds of trend that we've seen with the Oregon Behavioral Health cohort earlier. PHQ-9 scores and no-shows are strongly correlated. Ignore either one at your own risk, because if they don't show up to see you, they're showing up to see somebody much more expensive and probably less qualified to deliver what they need.
And one or two more messages. Remember that systems matter, systems matter, systems matter. Jay, just advance a few times here. I'll show you what's hiding in here. It is about access, okay? And this is kind of where I pause. This is Jay's epitaph on his tombstone. It's just going to say access, access, access. He shows up at a meeting looking for different ways to get people into our system, be it a high-risk clinic, open access, and all these other things. That's why we have such a big, giant urgent care built into our system. But I want to challenge people that open access is a two-edged sword. And this is why Roger Coleman would punch me in the nose if he were in the room with me. I think you've all had the Roger Coleman experience. He's one of these consultants who goes around the country and talks about open access. And it's great for those people who can navigate your phone system and those people who are able to get to your clinics. My problem with open access is that it is natural selection. Those with the resources are the ones who get those appointments. And the people you should be looking for are the ones often with the least ability to navigate that system. So the answer, open access is neither good nor bad. You have to keep an open mind about it. Remember that one size doesn't fit all. And always, always, always look at your system. You'd be surprised at who's going to the ER because they can't get in. And face-to-face visits, of course, the most cost-effective way to get what you need. And end over end, we keep reinventing healthcare every 6 months here. Our nurses are functioning at the top of their license. Maybe that stable hypertensive doesn't need to see somebody who's licensed with a clinician. Maybe they need a nice group visit or some supportive phone call. And of course, an army of community health workers running a nutrition class can and will change the world. So next slide. So as I wrap up here, it must be working. HRSA keeps giving us money. I don't know why, but more importantly, we talk about the triple aim: high quality, low cost, happy patients. Don't forget the quadruple aim of taking care of your workforce. These little things that we're doing with population health actually give people value to their work. And now for the 5th year in a row, we've gotten best places to work here in Rhode Island. So the staff seem to like it. So I'm going to keep doing it because it keeps them happy. One final slide. And of course, I want to remind you, you can't always get what you want. No, wait, risk adjustment matters. That was the theme here. These are my daughters at the Oregon Zoo a few years ago. And I'm happy to say that the daughter on the left and I will be out in just a few weeks on the tour looking for college. And we've got a trick question here or not. And we have to answer that immortal question when you visit. Is it Eugene or is it Corvallis? Because she's torn and I am literally deathly afraid to pick sides. But we'll be out in Oregon in a few weeks. With that, we'll open it up for questions. Courtney, do you want to do anything else?
No, I think we can open it up for questions, but I'd like to call out, we just spent an hour on a webinar, although a very entertaining one, an interesting one. It was still an hour on a webinar. So I invite everyone to turn your camera on and just like give it a wave, move around for a second so we can all have fun and talk to each other, hopefully with our cameras on. And
I got
I'll
two
do it.
votes for
I will look
Eugene. Yeah.
ridiculous with you. But please, yeah, join us in a conversation. I think my kickoff question that comes out, maybe other people have other ones that we should answer first. So as a little bit of background, I know Andrew mentioned in the beginning, so hopefully, I don't have it 100% confirmed yet, but in June, our final webinar will be with an MCO in Washington that is doing risk adjustment, that payment weighted Z code for homelessness, and they have a very specific model they use for that. It's an optional incentive. Hopefully he comes to present. So that's what Dr. Saul was referring to. But my question,
I hope I didn't spoil it.
Oh, no, that's okay. It's
But
just not 100% confirmed. I really hope it will happen. And then, so my question is from the FQHC side, since we know we're going to hear the payment side in a couple months, hopefully, how should these be weighted? I mean, beyond being able to risk stratify and predict total cost of care, from your perspective, how should they be weighted? And we can also leave that hanging and answer it at another time.
Yeah, because on one hand, if you weight it, then everyone puts their attention on it. I would say the answer is to do both. Even if they never ever weight these Z codes to drive the risk adjustment formulas, we know that's where the patients have the greatest need, and we are the interveners. So we need to keep risk stratifying, and someday the rest of the system will catch up. But Jay, if I were to say that risk scores start at 0, they're reset every January and they climb up, and you can see them as high as 1 or 2 or even 10. And every ICD-10 code, at least the good ones, have a little fractional weight. And like heart failure is like 0.6. Jay, compared to heart failure, where does homelessness rank?
Oh, it's actually pretty high. It's probably like 1.5. So, yeah. I mean, I think you have to put these into the same kind of logistic regression analysis that we put all the other medical diagnoses into. I think there's and weight them in exactly the same way, a Milliman would, for example. You could keep them aside and instead do some kind of a side-by-side social determinant risk score. And you could attach a differential payment to the social determinant risk score for patients. But in terms of how you would treat these, I don't see a reason to treat them any differently than we do any other diagnosis.
But don't wait for the insurance industry to catch up. If you see it, go for it. A lot of us are actually working with them, trying to say, hey, look at this. You're telling me that if somebody has an amputation below the knee, you're right, that drives total cost. You need the code to recognize that. But if they're doing that for an amputation and COPD, oh my God, unstable housing should have this weight that it should be like 2x. I mean, it's so prevalent. In ICD-11, which Europe is using, it's a little cleaner. There's still a chance that they may tweak ICD-10 to add more Z codes to describe more states of homelessness and other social determinants, but I haven't seen it come out of any of the committees yet.
Thank you. I invite everyone to jump in. You don't need to raise your hand. If questions came up for you, please ask them, or if something just resonated with you. We had some comments in the chat about the granularity of different definitions of homelessness really not matching the Z codes, which we know. So that was called out in the chat, but please, people, join in and ask your questions. And
Simon Parker Shames, I can see that. Yeah, Jay's answer that was regression analysis. That's how you figure out the number. Hooray for the MPHs.
Can I ask a question about, and I apologize if I missed it, but in particular, when you're looking at outcomes, are you stratifying by race and ethnicity, or is race and ethnicity language part of your risk model as one of the oftenly used as a social determinant, but not universally so?
Jay, you want to take it, or you want me to
We're
run?
embarking on it, Simon. The state is leading us through that. It's been a fascinating moment, I think, in terms of how you break it out, because there are known difficulties with the collection and classification of that kind of data on the individual level, much like Z codes. You know, the collection and classification don't necessarily fit, right? And so on an individual level, it's hard to make predictions, I suspect. And that will vary with exactly which of those REL categories you're talking about, of course. On the other hand, on a population level, I suspect those are going to reveal very interesting and potentially powerful insights to the community in terms of how they should be planning educational campaigns and support systems and drives to engage different segments of the population.
One of the side effects of building this data engine that we have, community health centers, we track race, ethnicity, SOGI and all these other things. When the pandemic hit, we not only knew our patients who were being tested and what the results were by race and ethnicity, we were tapped into the state HIE, that big health insurance information exchange. So if our patients, wherever they went in the state, the National Guard site, a hospital, if they were tested, we were able to pull the data. And so we had a slice of 60,000 people, race, ethnicity, age, zip code, zip +4, down to the neighborhood level, very, very granular. And it was very early in March when our data analyst called me and said, there's a problem with the data. And I said, is something wrong with the feeds? He goes, no, there's a problem in the data. Like, what are you seeing? He goes, the Latin people and the Blacks are running 3 to 4 times higher with the infectivity rate. That evening I had a call, and through the state health department, we're now best friends. When your community health center represents a slice of the state that's about 10% and it's all urban, broken down by zip code, your best friends are the state health department. So we were kind of the early canary in the coal mine that found that. Now that's just COVID. Remember, you've been doing this already. In table 7 of the UDS is blood pressure and diabetes and low birth weights. If you've not looked at your data, that is very, very powerful. The policy comes from good data. Good data gives good policy. Better policy can be made with good data. Use that to your advantage.
I have a question. I'm John Duke. I run our clinically integrated network that we're putting together. So my question is about that. We have we're starting up a clinically integrated network in Oregon, and we're planning to try to create a centralized data system that is very similar to what you're describing, but on a platform like Azara or Arcadia, and then we will dump all of the we'll interface with all the EHRs from all the health centers, but also put CCO claims data in there and possibly other databases that would enhance that data. How have you seen clinically integrated networks work in other environments, and how does that compare to this wonderful thing you have in your state where you've got this HIE that seems to be available to all of you?
Well, I think that's a great question, and I'm going to answer this partially by telling you I don't have much experience with a clinically integrated network per se, aside from the one I worked in, which is Care New, which I can't tell you was terribly well integrated. Our HIE, we've said it's wonderful, and it is wonderful, and it's going to be even better. It's opt-in, so it's not opt-out. So we've got great penetration of 60-70% of our patients. But a lot of the practices around us do not have that, some probably as low as 10% opt-in. So if you have a say in this, try to get it to be opt-out instead of opt-in. The advantages of a private information exchange, or PIE, are that you can make them opt out, upfront, as long as you've got that in your consent to treat forms, that kind of thing. You can certainly do what you're talking about, put it together on a platform like Azara or another analytics platform, integrated platform that's used to dealing with claims information. And that will do very well for you. The only downside potentially is that if the hospitals that your patients, for example, are going to are not a part of that clinically integrated network, you're not necessarily going to see what's happening there. So I don't know about the edges of your clinically integrated network, but that could be an issue. The claims will only come 3 months late unless someone agrees to give you an unadjudicated claims feed, which is uncommon, not unheard of, but uncommon. And then the other potential advantage of an HIE is that the CCDs are usually generated directly at the end of an encounter, so they're very timely, especially for office visits or consultations, that kind of thing. Unless you don't do your notes.
If you remember meaningful use, where you were generating reams of paper at the end of every visit, generating a visit summary, that is the moment where your EHR is creating the CCD document and it transmits to the HIE. Unfortunately, with meaningful use being not so meaningful or useful, we were generating paper and handing it to the patient, which would then go in the trash can. But yeah, so the CCD comes down right when you sign the note. It generates and off it goes to the exchange.
They were really never intended to be printed.
I know, I tried to tell them.
Yeah. So yes, you can do, so you can certainly do it that way. The other possibility would be that you could probably find an analytics platform that could be connected to exchange CCDs directly with an HIE. Something like that.
The technical side of the lecture, I know. For what it's worth, Rhode Island had one of the first HIEs in the country, and when they set it up, they were really cautious. So you only participate if you sign and say, yes, I want in. But every other state that set one up on the heels of ours said, oh, that was a mistake. And so they set it up so that you're in unless you actively opt out. And tonight I'm testifying at the State House once again, while we put a bill in there, can we change the HIE from opt out to, or opt, yeah. This has been going on for years. And our argument tonight is now 38 states have done this, including Mississippi. You don't want to be worse than Mississippi, do you? And then try and shame them, because, poor Mississippi is always number 49 or 50 and everything. Oh, sorry, Ashley, for the Oregon. I'm looking at that, the acronyms. Yeah, I'm guilty. If we are using acronyms that you want an explanation for, please just let us know.
Yeah.
I have a question. This is Lydia from Wallace. This question is a bit more removed. I'm actually so fascinated by the risk stratification talk. It's definitely up my alley. It makes me excited to be a part of this work. But I was wondering, earlier in your presentation, Andrew, you were talking about using the Prepare tool and how you had changed some of the questions, or you've altered them to be more
culturally and linguistically appropriate.
Exactly, which of course is wonderful. However, as many of us are probably thinking, Prepare tends to not let us change any of the questions. I'm wondering how you're able to change the questions.
Easy. We didn't use the Prepare tool, which is a proprietary copyrighted document.
Gotcha. I must have missed that part.
Stole the concept, right?
Okay.
So we found Prepare to be a bit too rigid, and they do want to have a nice say over what the product looks like. So we took the concept and ran with it, and we ended up with a very unique homegrown thing. It just smells like Prepare.
Gotcha. Thank you.
Hi, my name is Kavita Prakash. I'm the data analytics manager for this health center. And I've been working on a patient stratification model for the last year. And I can say, like right now I'm in the PCP validation phase where they're validating their panel on the model. And I can say that where we found that the model has missed, a lot of the times it is the social determinants of health, because that's a piece that I haven't incorporated in the model at the moment, because we haven't we haven't been collecting that data uniformly across the population, right? And so I'm really excited. This talk has been really fascinating for me, and I can say from experience that you know, it's very difficult to build a model if you don't have that piece of information. That information is very critical.
I think as a physician, I can say in fairness that we suffer from that street lamp phenomenon. You tend to look where the light is, and we've spent too long under the street lamp. You have to start going out and figuring out what you were not able to explain, right? And social determinants are definitely one of them. What's nice about social determinants is that much like infections, they can be cured. So unlike some other chronic conditions that can't be.
It is the ultimate selection bias. The American healthcare system is built around those who show up for care. So the only data you have comes from those who can show up. Yeah. And there begins the riddle of social determinants.
Yeah, and equity.
And to John Duke and everybody, I think we gave Courtney the slides, right? Oh, good.
So I think we have time for about probably one more question. I want to invite anyone who has a burning one to put it in the chat or to speak up. Also, I will say that I know all of our teams have been experimenting with different ways to share this data. And for the most part, they've been flat file feeds as part of this collaborative. So if you all have technical questions or you're starting to feel some pitfalls with that method, or just something to share about it, these are certainly two people who I think would be interested to hear that.
Yeah, more Gates than me. I'm the philosopher. He's the practical guy.
Oh yes, I like to break things or make them do things they weren't supposed to.
Oh, good. So I'm going to leave it with, we've got 2 votes for going to see Eugene and skipping Corvallis. I want to thank the room for their advice. I do appreciate that. I'll try and convince my kid now.
Mm-hmm. My parting advice is going to be something like this. I think we as a group probably thought we submitted all of our chronic conditions every year really well. And it actually runs around 55 to 60%. And that in turn means that your risk score is potentially dramatically under what it should be every year. So as you get into a contract along those lines, the first year, you don't need to fix it till you're done signing the contract, but you need to fix it right afterwards.
And just a reminder that the evil CMS computers on midnight on New Year's Eve, they reset everybody's risk scores back to 0. So if they had an amputation or they were on dialysis, they're magically cured.
Or they get a house in the future, right?
No, totally. So you got to keep resubmitting those scores. Courtney, back to you.
Yes, thank you so much. And also, if anybody has a follow-up question or you really are looking up into CCDA's acronym, I'm struggling with that one, at night tonight, and a question comes up for you, please let us know and we can get that to our guest presenters, Dr. Reese and Dr. Saul. So open communication. And as well, so as a reminder, these next steps, we have that workshop May 5th, May 13th, and May 20th. If you get nothing else from my updates today, please just remember team presentations on the first day. And then also, if you would like additional support, or if you're looking at these slides and you say, there's no way we have this information or we can't do this, just reach out to me and we'll create an alternative version or work on it together. And I think that's it. Does anyone have questions about workshop things?
I did have one. Sorry, this is Kendra from Virginia Garcia. This just came to mind like very last minute, but I was curious and I didn't catch it during the presentation. If you have recommendations or best practice on like the cadence for which you do your screening. I know that's a conversation we've been having about like annual screening versus every visit, because something that just came to mind when you made the comment about the codes or the things dropping off was this question we've had around resolving some of these determinants. So I know we just have a minute, but.
With the caveat that all EHRs suck, some suck less than others. One of the first things we did with ours was fix the health reminders. Now, health reminders is supposed to be along the lines of you need a mammogram. We were able to custom build in, you need a screening for depression or social determinants. We set it with a 12-month rolling look back. And that way, if it's done once for the year, hey, it's done and it's got a green checkbox. It's completely independent of the calendar year because you know what, it doesn't really matter with a 12-month rolling look back. But that began to save the medical assistants time. Oh, the box is green, I don't have to do it this time. The real thing to recognize though is who said it had to be done during the visit? And what can you do to get it done independent? And boy, that army of people on the phones or cell phone platforms, little incentives, whatever it takes to get it done is the right answer. Just don't crash your system. But a healthy built-in health reminder in the EHR can make or break your life.
Yeah, and that I suspect it's one of those kinds of information gathering that sometimes people feel more comfortable doing, you know, on a computer screen too.
Hey, well, I guess there's kind of two parts follow up to that. I mean, yes, you do the screening, but it's the follow up that matters. So I guess what is that flow? And then how are you tracking or resolving it in your system? Are you just resolving it once a year, or is there like an active workflow of like, if this has really been met, this needs to be closed out just like any other type of diagnostic?
There's actually two flavors when we find a gap in the social determinants. There is holy cow, house on fire, and then there's something that can wait till tomorrow. So if you're lucky, you've got integrated behavioral health in your clinics, and we do. Whenever we run into the hot flaming bag on your, when you don't know what to do, you call the IBH person, and they are very, very gifted at immediate crisis intervention and sorting it out. If it can wait till the next day, then we have a bevy of community health workers behind the scenes who either directly or indirectly link people to resources. And Jay, I think they track it on the back end. I don't think it's not in the EHR.
We have a report that comes out of the EMR that will tell us whether or not someone has had that addressed. And once our CHA is documented, the follow-up, they fall off that report.
Thank you.
So to your point, though, we're not following up 3 months later to see if it's still an issue. And I don't know, Kendra, about what cadence this should be, but for now, annual is enough.
Yeah, we aim for annual, but it's never miss an opportunity. So some of the medical assistants run crazy for the first quarter and then slack off for the whole year. But remember, the patients don't come in 4 times a year. They often come in 1, 2, 10, or 0 times a year.
Right.
So your best efforts at trying to define a cadence could drive you crazy because the patients are going to do what they darn well want to do when they access the clinic.
Okay, so I think we have just reached time. You all have my email. I will send out slides that will have Dr. Gates and Dr. Saul's emails, as well as if you just got a lot of curiosity about what our data director, Simon Parker Shames, does, or John Duke, who's talking about the shared information system, please feel free to reach out to us at OPCA and we can share that information with you. Okay. Thank you very much.
Courtney, can you stay on for a minute? And Jay?